بسم الله الرحمن الرحيم. في البداية أحب أشكر كل I would like to welcome all my eminent professors and chairman, and special thanks طبعا دكتورة علياء ودكتور تامر ودكتورة منال for the kind invitation to ThyroAlex 16. And for today, allow me to share this interactive case with you. So it will be an interactive session. I would like you to share your answers using the voting system. Have we voting system? By hands, okay. So our patient today was a 42-year-old female patient. She was presented with weight loss, tremors, and goiter back 12 years ago. And she had made diagnosis of toxic nodular goiter based on the ultrasound criteria and the thyroid function test. So the patient was admitted to perform total thyroidectomy back on 2008. Her surgical pathology report revealed the diagnosis of nodular colloid goiter, and there was no evidence of parathyroid glands. Unfortunately, on day 1 post-operative, the patient had the following symptoms of perioral numbness, paresthesia of hand and feet, muscle cramps, and carbobetal spasm like the photo. So I come to my first question for today. What is the most likely source of her symptoms? Hypocalcemia, hypothyroidism, hypercalcemia, or hypophosphatemia? A? Okay. Yes, definitely. It's an easy question, and I was expecting that most of you will get the right answer. So طبعا definitely this is a case of hypocalcemia, so I put this happy face despite it's not happy طبعا for the patient. So this is a case of post-surgical hypocalcemia. The most frequent cause is total thyroidectomy, and the symptoms of hypocalcemia usually depend on the degree and rapidity of hypocalcemia. Usually the patient manifested when the serum calcium is less than 8 milligram per deciliter. Symptoms usually mild, paresthesia, tingling, up to more severe symptoms, cramps, tetany, seizures, laryngeal spasm, and some arrhythmias in the form of prolonged QT intervals. Usually these severe symptoms occur with very severe level of hypocalcemia when the calcium is less than 6 milligram per deciliter, or in periods of prolonged hypocalcemia resting for 4 or more days post-operative. So at this time, which of the following is the least useful diagnostic test for our patient? Intact parathyroid hormone, ionized calcium, phosphorus, or TSH? A, B, C, or D? Yes, I hear. D, yes, of course. Yes, this is a case of post-operative hypocalcemia, most probably due to hypoparathyroidism. So we need to search for the cause of hyperthyroidism by measuring the parathyroid hormone, calcium, phosphorus, and the least diagnostic will be TSH. As mentioned elegantly by Professor Ma in her lecture, there are criteria or predictors for the occurrence of hypocalcemia, mainly the preoperative vitamin D levels, early postoperative parathyroid hormone levels, and postoperative calcium changes. So we need to check these in every patient performing thyroid surgery. The hypocalcemia occur post-operative is usually related to whether accidental removal of the parathyroid glands, vascular damage, or even extensive surgical procedure. Fortunately, most of the patients develop transient hypocalcemia that starting hours up to less than 6 months post-operative, and only 1/3 of the patient may develop permanent hypocalcemia that may last for up to 6 months. However, fortunately, 1/3 of these patients will return to normal calcemia within the first 1 year, as mentioned by Professor Ma. So we have to wait till the first 12 months before deciding whether type of hypocalcemia, and this occurs due to the recovery of the parathyroid glands from the surgical insult within the first year of surgery. So back to our patient, her serum calcium was 4, and albumin was 3.5, and we used the famous equation to calculate the corrected calcium, which equals calcium plus 0.8 by 4 minus albumin, and her corrected calcium was 4.4, which is definitely low. So what is the most appropriate next step in her management? Start oral calcium carbonate, intravenous infusion of calcium gluconate, recombinant parathyroid hormone, or A and B. Yes? Yes. Okay, let's see how to manage post-operative hypocalcemia. So patient went whether thyroid or parathyroid surgery. If they develop symptoms of hypocalcemia, you have to check the calcium status, and you have to give the patient IV infusion of calcium gluconate around 2 grams for glucose infusion, around 15 milli for 15 minutes. If the patient didn't develop symptoms of hypocalcemia, you have to check both calcium, phosphorus, alkaline phosphatase, and intact PTH within the first 18 up to 24 hours post-surgery. If the patient's serum calcium is less than 6.5 milligram per DL, then you have to start giving parenteral IV infusion of calcium gluconate in a dose of 8 grams for 24 hours. It should be combined with oral calcium carbonate in a dose of 6 to 8 grams per day, together with active vitamin D analogs with calcitriol or alpha-calcidol 4 mic per day, and you have to check the calcium daily. If your patient calcium was ranging between 6.5 and 7.6, you have to give both parenteral and oral calcium in less doses. IV calcium gluconate in dose of 4 to 6 grams within 24 hours, with calcium carbonate 4 to 6 grams per day, together with active vitamin D 2 mic per day, and check the calcium daily. If the calcium of the patient is more than 7.6, and some authors prefer 8, no need to start parenteral calcium, and you can only maintain your patient on combined oral calcium carbonate in a dose of 2 to 4 grams per day, and active vitamin D from 0.5 to 1 mic per day, and you have to check the calcium level on alternate days. Here is another way for management of post-operative hypocalcemia. So when the patient who underwent total thyroidectomy, you have to keep your patient on calcium carbonate in a dose of 1 gram every 6 hours, and check intact PTH as early as possible post-operative, because as we mentioned before, it's a very strong protector for the occurrence of post-operative hypocalcemia. If the parathyroid hormone turns back to be less than 10 picogram per ml, this is a strong predictor that this patient may develop post-operative hypocalcemia. So you have to increase the dose of calcium carbonate and add on vitamin D analog, and discharge your patient on high dose of oral calcium up to 6 grams per day, and active vitamin D in a dose of around 1.5 mic per day. If the parathyroid hormone is from 10 to 15, then at this time you can discharge your patient on a less dose of calcium and vitamin D. And finally, if the patient parathyroid hormone is more than 15, as Professor Maha mentioned, this is a good predictor of to avoid hypocalcemia post-operative. Then you can only discharge your patient on calcium supplements in a low dose of 1 gram twice daily, together طبعا with thyroxine replacement therapy and main pain medication as needed. The commonly used calcium supplements, we have many calcium salts, calcium carbonate, citrate, phosphate, and gluconate. The most commonly used هو calcium carbonate because it has the highest elemental calcium per weight اللي هو 40%. Moreover, it's the least expensive one. Regarding the calcium gluconate, it has the least elemental calcium, only 9%, so it's used mainly for the intravenous infusion for treatment of cases of severe hypocalcemia, despite it's well absorbed. Back again to our patient. طبعا the patient was presented with severe hypocalcemia, so the patient received intravenous infusion of around 3 grams of calcium gluconate. It was repeatedly several times because of repeated attacks of spasm for the first 3 months post-operative till the patient achieving normocalcemia. So the patient was discharged on the following treatment: 2 tablets of calcium carbonate every 8 hours, alpha-calcidol, 1 mic every 24 hours, and levothyroxine replacement in a dose of 100 microgram per day. Unfortunately, in the last 2 years, the patient was presented with daily crisis of cramps despite the medical treatment in the upper limbs, having the clinical and laboratory diagnosis of hypocalcemia. So she received IV infusion of calcium gluconate around every other day for around 1 week till the symptoms were improved, and then the patient was advised to continue on medical treatment. The vitamin D analog 1 mic per day and calcium carbonate 2 grams per day were prescribed. During this period, her follow-up serum calcium was maintained on the no normal level, 8.4 or 8.1 repeatedly. However, the last month she was presented with a carpopedal spasm again and numbness, and her calcium at that time drawn back to 6.2, which is definitely low. So at this time, what's the best, next best investigation that would help in our management? To perform neck ultrasound, measure magnesium level, measure potassium level, or measure the phosphorus level. So. What do you think? 2? B? Yes. So our patient suffer from a lack of response to medical therapy, so we have to search for potential causes of refractory hypocalcemia. One of these important causes is magnesium depletion. And the magnesium was found to be very important for the action and production of parathyroid hormone. It acts as parathyroid hormone secretion cofactor by sensitizing calcium receptor. The hypocalcemia occur in magnesium depletion it was due to reduced calcium mobilization from the bone, lack of bone response to parathyroid hormone, and low levels of cyclic AMP, which is a marker for parathyroid hormone activity. And some studies showed that if there is a slight reduction in serum magnesium, it will stimulate parathyroid hormone. However, with more depletion, it can inhibit or affect the production of parathyroid hormone, leading to hypocalcemia. Back to our patient, her magnesium level was 1.3, with normal level from 1.2 to 1.7, which is accepted level or low normal level. We revised back her calcium supplements, and it was containing oops. Okay. المغنيسيوم oxide salts. الدوز كانت around 200 milligram per 3 tablets. However, the patient didn't show any improvement regarding her symptoms or calcium level despite the treatment with calcium carbonate in dose of 2 grams per day and vitamin D analog in dose of 1 mic per day. So what do you think will be the next step in her management? Start magnesium supplements, shift to cholecalciferol, increase the dose of levothyroxine, or increase the dose of calcium and vitamin D. A, okay, no. Hey. So, the patient already receiving calcium carbonate, okay, which contained magnesium, and her magnesium was in the normal range. So, and despite this, she was on a low dose of calcium and vitamin D analog. We can increase the dose up to 8 grams, sometimes 12 grams calcium per day, and 4 mic of vitamin D per day. She was only on 2 and 1 mic per day. So we advise the patient to increase the oral intake of calcium carbonate up to 8 grams per day, together with alpha calcidol, reaching 4 mic per day. But unfortunately, the patient had poor digestive tolerance to tolerate this very high dose of calcium, and she refused صراحة to increase the dose. So she required frequent intravenous infusions for calcium due to hypocalcemia. At that time, we asked for a full panel of calcium laboratory investigations, and it turned back to be her ionized calcium was 3.1, which is low, phosphorus 5.3, which is high, 24-hour urinary calcium was 48, which is low. Intact parathyroid hormone was 6.8, which is definitely low. 25-hydroxyvitamin D was 49, which excludes vitamin D deficiency. And finally, her PTH was 0.65, despite my medical treatment. So what is the most appropriate next step in her management finally? Would you like to start recombinant parathyroid hormone, or start intravenous calcium again, increase the dose of vitamin D, or decrease the dose of calcium? Yes, A, okay. Yes, I totally agree with you. So at this time, we decide to give a trial for recombinant parathyroid hormone, in this case of refractory resistant postoperative hypocalcemia. The structure of normal parathyroid hormone contain 84 amino acid polypeptide chain, while we have 2 currently available preparations of recombinant parathyroid hormone, intact 184, and the teriparatide, which is 134 parathyroid hormone. The recombinant parathyroid hormone was FDA approved for the treatment of osteoporosis to increase the bone mass. However, it's used off-label successfully in hypoparathyroid patients or patients with hypocalcemia. However, طبعا في minor side effects من الباراثايرويد هرمون injections, mainly الhypercalcemia والhypercalciuria. However, there was no reported cases of nephrocalcinosis, even patients on teriparatide, their calcium creatinine ratio never exceeds 0.4. Finally, it's recommended to use the recombinant parathyroid hormone with caution with certain drugs, including digoxin, the high dose of hydrochlorothiazide, والفريزيمايد to avoid the occurrence of hypercalcemia or hypercalciuria that may precipitate digoxin toxicity. As we mentioned, we can use a recombinant parathyroid hormone off-label for treatment of postoperative hypocalcemia and hypoparathyroidism. It was here a case report published last year in Turkey, a Turkish female patient. She was a 52-year-old female patient with Graves' disease who underwent total thyroidectomy on 2000, and she was treated with replacement therapy, levothyroxine, calcium, and vitamin D. However, she had multiple hospitalization and emergency admission for hypocalcemia, recurrent hypocalcemia, and she received multiple intravenous infusions of calcium. Despite that, her calcium was low, while phosphorus was high, while PTH was very low, so the physician decided to give her teriparatide, and on treatment, she showed improvement. There was no hospitalization within the first 9 months of treatment. Even more, her calcium has increased to 7.4, and phosphorus has dropped to 2.7 on treatment. Another patient who diagnosed with stage 4 cancer larynx, and he underwent total laryngectomy together with total thyroidectomy and extensive resection of the surrounding tissues. He was replaced on levothyroxine, calcium, and vitamin D through the nasogastric tube. However, the patient developed postoperative unresponsive hypocalcemia and hypercalciuria, reaching up to 900 milligram per day calcium in urine. So teriparatide was started, and it allowed for more reduction of his oral calcium and vitamin D after 2 months of treatment. So So we can conclude that the use of recombinant parathyroid hormone is a good option for patients with resistant hypoparathyroidism or hypocalcemia. However, we need طبعا long-term follow-up studies involving large number of patients to consider in terms of its side effects and complications. That's our last slide. 1 minute. So back again to our patient. At the time we she started treatment with teriparatide. We choose teriparatide because it's available in our country. Teriparatide in a dose of 20 mic every 12-hour subcutaneous injection was started, which allowed for more reduction of her calcium and alpha-calcidol intake. Moreover, a patient digestive tolerance was improved, which she need no further intravenous calcium to maintain her normal calcemia. So my dear professors, chairman, and colleagues, my take-home message, this was a case of late hypoparathyroidism, which is a clinical presentation in which hypoparathyroidism manifests months or years after thyroid surgery. There is one explanation for this, that may be scar retraction of parathyroid glands handled and hypovascularized before in the surgical bed that leads to consequent worsening of hypovascularization. Vitamin D deficiency and Graves' disease are considered two predictive factors. Treatment includes intravenous injection of calcium gluconate for treatment of severe hypocalcemia, and finally, recombinant parathyroid hormone is an option for these patients unresponsive to the conventional therapy. And thank you.